point-of-care ultrasound for assessment of fetal well-being. POCUS is invaluable in patient care because it allows ultrasound assessments to be performed at the bedside with scan results interpreted directly by the treating clinicians. It is used for both diagnostic purposes and to guide procedures. The real-time nature of POCUS enables clinicians to make timely diagnosis and assess complications, particularly in urgent situations. The primary goal of POCUS is to answer specific clinical questions or achieve a procedural objective quickly and efficiently. However, there are some disadvantages to POCUS. As we know, ultrasound assessments are operator-dependent, and inexperienced operators may produce suboptimal imaging. Beyond the quality of the scan itself, accurate interpretation of the scan findings is crucial. Misinterpretation can lead to suboptimal patient care. Therefore, it's essential to provide high-quality training, such as this POCUS course, to ensure clinicians developing strong POCUS skills. POCUS should not replace comprehensive scan performed in a dedicated sonography department. And proper documentation of scan findings in the patient records is critical, especially since images are often not stored on a bedside ultrasound machines. The common indications for assessing fetal well-being using POCUS included reduced fetal movement, inability to auscultate the fetal heart rate, abnormal fetal heart rate, and various obstetric complications as listed here. These situations frequently arise in everyday practice within an obstetric unit. As illustrated in the previous slides, various clinical presentations require fetal assessment by POCUS. As with any patient evaluation, this is important to take the clinical history into account. Ultrasound assessments are conducted at the point of care, allowing clinicians to interpret scan findings in the context of the overall clinical situation before formulating a management plan. There are several possible management options, such as urgent delivery for abnormal fetal well-being, or if the fetal condition is stable on scan, to manage according to the maternal complications, or to refer the patient to maternal fetal medicine for further evaluation, for example, in cases of suspected fetal arrhythmia. For measuring the fetal heart rate, M mode is preferred over pulse wave Doppler because it has a lower energy output. Pulse wave Doppler should be avoided in the first trimester. To begin, obtain a 4-chamber view of the heart, then position the M mode sampling line over the fetal heart. In pulse wave Doppler, the gauge should be placed over one of the atrioventricular valves. Observe whether the heart rate is regular, both on the cardiac cycle trace and through direct visualization of the cardiac contractions. The fetal heart rate can then be measured. You may adjust the sweep speed to capture more cardiac cycles in a single image, which improves visualization of the pattern of cardiac rhythm in cases of irregular heart rates. Be cautious of fetal movement or breathing, as these can create a false impression of an irregular heart rate by displacing the Doppler gauge or MO sampling line. The normal fetal heart rate has a regular rhythm, ranging from 120 to 160 beats per minute. Persistent bradycardia, defined as a fetal heart rate of less than 110 beats per minute, is considered abnormal, as are recurrent heart rate decelerations. Persistent tachycardia, categorized by a fetal heart rate exceeding 180 beats per minute is also abnormal. An irregular rhythm should prompt a referral to maternal fetal medicine unit for further evaluation. Mild transient tachycardia associated with fetal movement is often a normal variant. Transient bradycardia in an otherwise normal and well fetus during the second trimester may be related to pressure from the transducer and is generally not of clinical significance. Always consider the clinical background and context. Fetal bradycardia may be linked to fetal hypoxia or, less commonly, a congenital heart block. The clinical context is crucial for guiding the interpretation and final diagnosis. In women with risk factors or obstetric complications related to fetal hypoxia, or during labor, fetal bradycardia often indicates fetal hypoxia. Conversely, in women with otherwise uncomplicated pregnancies, fetal bradycardia may be associated with congenital heart block, which typically develops between 16 and 30 weeks of gestation. Persistent fetal tachycardia can be associated with fetal hypoxia, chorioamnionitis, or fetal tachyarrhythmias. For instance, in a woman with PPROM and fever, or during labor with fever, persistent fetal tachycardia strongly suggests chorioamnionitis. In women with risk factors for fetal hypoxia, such as fetal growth restriction or during labor, may indicate fetal hypoxia. A fetal heart rate above 220 beats per minute is often associated with fetal tachyarrhythmias. If a fetal arrhythmia is suspected, assessing for signs of fetal heart drops can provide useful information during referral to maternal fetal medicine unit. Here are examples of a normal fetal heart rate as measured by MO here and pulse wave Doppler. Fetal heart rate measurement requires 4 cardiac cycles in the setting of this machine. So you can see this is 1 cardiac cycle, 2 second cardiac cycle, 3rd cardiac cycle, and 4th one. So hence we measure the fetal heart rate here. This is an example of fetal supraventricular tachycardia, SVT, as illustrated in the ultrasound image. It's a fetal tachycardia with the fetal heart rate 235 beats per minute. And you can also note the markedly abnormal appearance of cardiac contractility here. Diastole is significantly shortened, resulting in reduced filling times for both the atria and ventricles. This leads to increased ventral venous pressure and ultimately may result in a heart failure. This is an example of an irregular heart rate. Here we increase the sweep speed to capture more cardiac cycle in the image, allowing for better appreciation of the fetal heart rate pattern. As you can see, there is a period of normal fetal heart rate here, with a fetal heart rate 148 beats per minute, then followed by a period of tachycardia here. The heart rate here is 235 beats per minute. A fetal echocardiogram later confirmed this is a case of atrial tachycardia. Next, I will discuss amniotic fluid measurement. Should we use deepest vertical pocket or amniotic fluid index? We use deepest vertical pocket method to diagnose oligohydramnios. This approach is associated with fewer instances of induction of labor compared to the use of amniotic fluid index, while achieving similar perinatal outcomes, according to a Cochrane review. Amniotic fluid index is preferred for assessing polyhydramnios. Regarding the technique for measuring amniotic fluid volume, the ultrasound transducer is positioned perpendicular to the maternal abdomen to identify the pockets of amniotic fluid. For measurement of deepest vertical pocket, the deepest pocket in the amniotic cavities is measured. In contrast, for AFI measurement, the fluid pockets in all 4 quadrants are measured, and the AFI is calculated as the sum of these 4 pockets. If necessary, we use ultrasound Doppler to exclude the presence of umbilical cord in the fluid pocket. There are the normal ranges of amniotic fluid measurement here. Displayed here are examples of oligohydramnios and polyhydramnios. We use the DVP method to diagnose oligohydramnios as illustrated here. And we use ultrasound Doppler, color Doppler to exclude presence of umbilical cord. So make sure we are not measuring, including the umbilical cord in the measurement of the pocket of fluid. In cases of polyhydramnios, we use AFI for to measure the amniotic fluid volume. In the last part, I will briefly discuss twin pregnancies. During the ultrasound scan for twins, you first starting by sweeping the transducer vertically up and down, and then horizontally to identify and label each twin. It is ideal to refer to the twin labels in previous ultrasound reports for consistency. Fetal heart rate measurement is conducted as in singleton pregnancies. When measuring amniotic fluid volume, be sure to assess the intertwin membranes, except in cases of MCMA twins. So then we measure the deepest vertical pocket for each twins. At times, it may be challenging to identify the intertwin membranes, which could raise the suspicion of oligohydramnios in one of the twins. Make sure to examine the area around the fetus, particularly around the legs, and this is where you are more likely to see the membranes and pocket of fluid. Additionally, be mindful of any risk factors for oligohydramnios, such as fetal growth restriction, twin-twin transfusion syndrome, or PPROM. In conclusion, POCAS enables timely measured assessment of fetal well-being at the point of care. High-quality training is essential to ensure the accuracy and effectiveness of these assessments. In addition to obtaining high-quality scans, robust interpretation of the findings is crucial for optimal patient care. Proper documentation of scan results is essential for maintaining records and meeting medical legal requirements. Thank you.